Doctors, we are live on YouTube now. So, with all your due permission, we are starting the session today. Good afternoon and welcome to one and all. I'm Rituparna from Clearnet, designated session assistant for a seamless experience, and Clearnet is India's most trusted and widely used digital platform with multiple enriching services exclusive for doctors. Clearnet is very proud to be a digital partner for this event organized by the National Neonatology Forum, Gujarat. And the topic of today's session is panel discussion on rational need on neonatal screening. So without wasting any further minute, let's begin today's session, for which I would like to invite Dr. Prashant Karya, the Honorable Secretary of NNF Gujarat, to take over. Sir, please proceed. Thank you.
Thank you. On behalf of NNF Gujarat, I, Dr. Prashant Karya, Secretary of NNF Gujarat, welcome one and all to today's neonatal Pathshala. Today we'll be having a wonderful discussion on rational neonatal screening. And for welcoming the guest, I request our President, Dr. Dipen Patel, to welcome one and all. As you all know, we are usually having this link which is fixed every Wednesday, 3:30 to 4:30 p.m. So I request Dr. Dipen Patel to welcome today's experts. Thank you.
Good afternoon, dear colleagues. Today, on behalf of Gujarat NNF, I welcome you all on today's panel discussion. We have moderator Dr. Vishnu Mohan and experts Dr. Nehal Madam, Dr. Snehal Madam, and Dr. Biraj Madam. So we have a great team with us. We will learn newer concepts and we will recap our older knowledge through this online platform. So again, welcome you all on this innovative digital platform. I request Dr. Prashant Karya to proceed further.
Thank you so much. So on behalf of NNF Gujarat, again, we welcome one and all. Today's moderator, Dr. Vishnu Mohan, is a neonatologist from Kerala, and he was a key member secretary of IAP STG guidelines. And he's a very much dynamic and active neonatologist. So I request Vishnu to start his presentation. Along with him, we do have Dr. Nehal Patel, Dr. Sheetal Sharda, and Dr. Biraj Thakkar as our experts. Thank you.
Thank you, Prashant. Respected seniors and my dear friends who have joined online on this platform today. First of all, let me take this opportunity to thank NNF Gujarat, especially my friends, Dr. Dipen and Dr. Prashant, for this wonderful initiative that has been going on, I think, for more than a year, no, Prashant? Yeah, so which has been really appreciated all over the country from our fraternity in neonatology and pediatrics. So congratulations NNF Gujarat for this great initiative, and thank you very much for making me a part of this program again on this afternoon. So I'll just share my slides. So today we'll be having a panel discussion on rational need of newborn screening. So, as mentioned earlier, we have three experts with me today. Dr. Sheetal Sharda, who is the Director of Clinical Genomics Development and Implementation at Newburgh Center for Genomic Medicine, Ahmedabad. Dr. Biraj Thakkar, who heads the Neonatology Department at Ankanksha Hospital in Anand. And Dr. Nehal Patel, who is the Head of the Department of Pediatrics at Jeemers Medical College, Ahmedabad. So why this topic? So we have around 140 million births globally every year. 4 million of them are born with congenital problems, and 25% of the sudden infant deaths are expected to be inborn errors of metabolism. So overall, the global incidence of IEM are around 1:1,350. And neonatal screening is the best known preventive pediatric public health initiative globally. And still in India, we do not have a clear-cut guideline for newborn screening. So it all started in 1960 in the United States of America when Dr. Robert Guthrie developed the screening for phenylketonuria, which was detected with bacterial inhibition assay. 18 years later, 10 years later, they started screening for congenital hypothyroidism, and 20 years later, TMS evolved and started being used in practice. And 18 years later to that, in 2008, we started our neonatal screening programs in India, initially in the state of Goa. So TMS, which was a landmark discovery, it's a very economical and cost-effective technology, which uses very small sample volume, around 40 conditions screened from a single blood spot, fast turnaround time, less than a day, and very high sensitivity. So the criteria for what diseases to be screened is termed after Wilson Jugner. So the disease should be an important health problem. Natural history of the disease should be well understood. It should be detectable at an early age. Treatment at early stage should be beneficial to the family. Test should be acceptable. Cost should be balanced against benefit, and this should be less than the benefit. So what are the common diseases that we screen in our part of the world, in India? So we usually screen for congenital heart diseases, hearing, congenital hypothyroidism, CAH, and G6PD deficiency. And what all other screening tests which are available? We routinely use clinical examination as a screening tool, pulse oximetry screening, which is again used widely of late, hearing screening, and blood spot screening. So my first question to Dr. Nehal. So what all do you screen for or do you look after when a baby is born in the head-foot examination, or as a routine, the VBD screening, visible birth defect screening? Dr. Nehal.
Good afternoon all, and thank you Neonatal Pathshala for involving me in this neonatal screening program. We generally screen birth defects every time when we visit the delivery room and the birth of the baby occur. So important is the physical screening, which is from head to toe. The RBSK, Rashtriya Bal Swasthya Karyakram, it has given a beautiful poster so that majority of the major birth defects, they cannot be left out in screening. So first, starting from the head to spine, the meningocele, myelocele, encephalocele, then in the eyes, if there is glaucoma, cataract, in the ear, there are deformed ears, cleft lip, cleft palate, anal atresia, omphalocele, there may be genital abnormalities, the urinary tract abnormalities, prune belly, then limbs like phocomelia or simple minor limb anomalies, extra finger, anything, CTEV, this all can be screened. And this chart should be there in the delivery room so that each and every person can go through it and nothing is left out. There are some child which are also developed with the dysmorphic features. Like if we know that the Down syndrome, we know what to look for. Likewise, there are many chromosomal syndromes which can be seen by just screening the face and the other anomalies. So that should be how the physical screening should go.
Thank you, Dr. Nehal. Dr. Sheetal, I think Dr. Sheetal is a person who has a keen interest in dysmorphology as well. So, Dr. Sheetal, would you like to add on a few points to that?
Hi, good afternoon, everyone, and thank you to the organizers for inviting me to this interesting topic. I think this was more of a revision for me than an expert, because I went to those days when newborn screening was almost picking up, I would say, but it has been 50 years and still we are not at that level which we expected, that at least the routine screening should start. But as rightly pointed out, screening just doesn't mean that we have to look for genetic disorders or inborn error of metabolism, the various types of abnormalities. So these are major malformations which will be easily picked up. But there are also certain subtle minor malformations in a baby. If there are more than 2 or 3 minor malformations, we have to screen them for some major malformation. So for the initial stages, yes, these are all very important things. More so because unfortunately, many of these may not be viable also for a long time. And the parents may want to know what is the risk in the next pregnancy. So a very good clinical description, I say, is the best test for any diagnosis rather than any other, advanced testing. So just note down whatever is there, and it is not always necessary to give a name to that syndrome. But if we just mark all the symptoms or all the malformation present on the card and give it to the parents to store it, or take a photograph and store it. Now everybody has smartphones. So if they can just store it, it becomes very important to discuss the risk of recurrence in the next pregnancy. So I would just like to add that prevention is not just for one baby, it is for the family, for prevention for the next baby also.
Perfect. Thank you, Dr. Sheetal. And adding a note to that, so with the evolution of our perinatal medicine, the antenatal screening is also of really important. So the 13 weeks onwards, we need to be having a very keen eye on having proper antenatal scans, 13 weeks as well as 20 weeks anomaly scan. So I think almost every part of our country, the field of like antenatal screening has evolved to a great extent that has also been contributing to preventing births with major defects. So moving on from clinical screening to the next screening, congenital heart disease screening. So Dr. Biraj, would you like to elaborate on the screening practices for congenital heart diseases in your unit? Dr. Biraj?
Yeah, I'm here. Yeah, so congenital heart diseases are to be screened with the pulse oximetry screening test. And that is quite important because the CHD, if you look at the incidence, the major cause of the death, like 5 to 10% of the infants, mortality is because of CHD. And out of those, 25% of the CHDs are life-threatening. So it is good to get screening done for the CHDs, and then if required, then get for the echo done. And pulse oximetry screening is the test which is being used for screening the CHDs, and it has a good sensitivity as well as specificities. So what test? That is the pulse oximetry test, and that is to check the pulse oximeter, like oxygen saturations of right upper limb or either of the foot. So pulse ox should be checked at two places. One is at the right upper limb and either of the foot. And then it is to be checked between 24 to 48 hours of the birth. And if child is getting discharged earlier, then the pulse oximetry test to be done even for less than 24 hours. And it's not only for the high-risk baby. This test is to be done for each and every newborn. So there should be universal screening rather than only screening the high-risk newborns. And how do we interpret this test? If the pulse oximetry reading is more than 95%, that means if sets are normal for more than 95% or 95% in upper limb as well as the lower limb, and the difference between the upper limb and lower limb is less than or equal to 2. So then this is a normal test and the test is negative. So the baby does not need for checking the echo done. So if saturation is 95 in upper limb and 95 in lower limb and 97 in upper limb, that's fine. And if the sets are less than 90, then the test is positive. That means the test is abnormal. So this child should go for the echo testing done. But if the sets are between 90 to 94%, what should be done in that case? If sets are between 90 to 94% plus upper limb and lower limb, that is the preductal and postductal difference is more than 2, that is the difference of 3%, then this test is to be repeated 60 minutes later. And if baby's saturation improves to 95 and more than that, then it is normal and test is negative. But again, the sets are on the lower side, then that child should undergo echocardiography.
Okay. So is there any congenital heart disease that cannot be screened by pulse oximetry?
Yeah, so there are diseases where there is no mixing of the blood. That is like left-sided obstructive disease. If there is a coarctation of aorta, but without PDA, without VSD. So if there is a atresia even, then if there is no mixing being done, those diseases can be missed out. When there is a left to right shunting wale diseases, VSD, all this can be missed out in this pulse oximetry screening test. This can pick up the major cyanotic CHDs and where the mixings are being done.
Thank you, Dr. Biraj. So, as she was telling, this is one of the small, lesser investment, cheap screening programs that has gone a long way in detecting babies with congenital disease. So, Dr. Nehal, how do you practice screening for jaundice in your unit?
Yeah. So screening of the jaundice, the day-to-day screening of the jaundice, we definitely do first clinically, and that is by palm pressure and to the different areas from head to toe. And that is we have the classification, that is Kramer's classification. After the clinical estimate of the jaundice, we go for the another method to confirm our clinical interpretation, and that is we can go for the non-invasive test, which is transcutaneous bilirubinometry. The picture shown it one instrument where the it is just pressed and the readings come into the milligram per dl. The another instrument is also available, which needs to be attached to the ear lobule or ear pinna. Now, with this transcutaneous bilirubinometry, we have the graphs available to stratify the children into the risk zone, whether it is low risk, high risk, or medium risk. We need to confirm this transcutaneous bilirubinometry with the serum bilirubin if the child comes into intermediate or high risk, and also if we are sending the patient home with the intermediate risk and borderline bilirubins. So the low risk to child can be followed up in 3 to 5 days, low to intermediate in the 48 hours, and high intermediate within 8 to 12 hours. Or so this high risk need to be admitted and rechecked again within 8 to 12 hours or 4 to 8 hours.
Okay. So, thank you, Dr. Nehal. So, since the evolution of transcutaneous bilirubinometry, the screening of jaundice has become much more simpler. And it's very important that we use these charts to determine when to follow up these babies. And again, more importantly, it's very important that you use the bind scoring in your rounds to document the severity of jaundice and in these babies. So another screening practice that we widely use regularly is hip dysplasia screening. And it's very important that we practice this regularly for every baby who is born in our unit. So Dr. Biraj, would you like to elaborate on how you screen for hip dysplasia in your babies?
Yeah, so basically, this is DDH, is developmental dysplasia, and that is the displacement of the hip from the acetabular cavity. That is like either partial displacement or complete displacement. And in this test, which we are going to use for the screening, we are either going to displace the hip or we are going to replace the hip. And at the time of displacing and replacing, we are going to hear some sound. So it's not important just to listen to that sound. Along with sound, you can also palpate the head, the femur. So that is what the test is. So side one test, and there we are just keeping the hip in adducted position. From abductions, we just keep the hip in the adduction, and at the same time, while the hip inside, we feel the hip head as well as the we can the sound, the sound. So both the things are important. And the side one, that is the biceps, where hip are adducted. At that time, the position of the hip should be 90-degree flexed as well as the 90-degree flexed at the knee joint. So hip joint and knee joint both are 90-degree flexed. And from that positions, from adduction, we are just keeping, from abduction, we are just keeping the things abducted. So at that time, we can feel the click sound. So while performing this test, always perform Barlow's first, that is of right side one first, right side of the screen, which has been shown in the picture, and ortolon is later. So first you displace the hip and then you replace the hip.
Okay. So any warning signs like before examination, like in your clinical examination, how do you identify risk for these babies?
can find just looking at the displays, the limb length, and if you just flex these won't be at the but it may be difficult. That's why the screening is important, because this is the things which can be missed out. So if you screen that and you can feel the cluck sound along with the displaced hip at that time, you can have idea. And the second thing is history. Definitely, if there is a history, you can go for the thing.
So asymmetric thigh and
Breech
skin.
presentation, also for female. So these are the risk factors where you just specifically look for this test. Otherwise, it is to be done for each and every one.
So it's very important that you screen every baby for DDH. So going on to the next screening modality, Dr. Nehal, how do you practice routine eye screening in your unit?
Yes, so for routine eye screening, like each and every newborn, we need to check the eyes specifically for the cataract or any vision abnormalities. For this, we need our NICU to convert it into the dark room, like so switch off all the lights. Generally also the dimmed lights are preferable in the NICU. Only if rounds are going on and you want to look for the child, then only the examination lights are needed. Otherwise dimmed light will be preferable. But here we need to switch off the light so that the dark room will be created. And then in this we can use the ophthalmoscope with newborn with the a good distance from the newborn, and then we can check the reflex into the both the pupils. Now, if the child is older, we can practice as like this is in the OPD by assessing the room sitting 1 to 5 feet away and allow the pupil to be dilated in around 10 seconds. And if the infant is there, place the infant in mother or the caregiver's lap and with the shoulder which is facing backward. Now set the ophthalmoscope to the lens power of 0 degree and then look through the instrument to the entire face of the child, which is clearly focused, and light project onto the both the eyes simultaneously. You can see the reflection in bilateral eyes individually and together. The schedule is at birth, then at 6 months, then 12 months, 24 months, and 25 to 36 months. The interpretation of the red reflex is normally there should be reflection in both the eyes and with the same intensity, same color and clarity without any opacity. But if you find any dark spot or decreased reflex or white colored spot or any asymmetry, then that is considered as abnormal, and the child should be looked for any congenital anomaly of the eyes like cataract, glaucoma, retinal abnormality like retinoblastoma, and other high refractive disorder or the systemic diseases with the ocular manifestations.
Thank you, Dr. Nehal. So it's really important that we practice these simple things, which can be done in a minute's time, so that it's very important medico-legally as well. So going on from the eyes to ears, Dr. Biraj, how do you practice routine hearing screening in your unit? Dr. Biraj?
Hello.
Yeah. So eyes to ears, how do you practice your routine hearing screening in your unit?
Yeah, so hearing screening is to be checked for each and every newborn before 3 months. So immediately, as soon as the baby is born, within after 48 hours, the hearing test is to be done. That should be universal hearing test, not only for the specific patients. And if there is a hearing problem, like if OA is referred, then it is to be rechecked 6 weeks later. So the commonest cause for the newborn for the hearing loss is CMV. So torch infection, CMV infections, which leads to the sensory neural hearing loss. So if there is a hearing loss, then one should check for the CMV as well. And there are other causes, like in case of NICU graduates, baby might have received many ototoxic drugs, Lasix, and this all are the cause for hearing loss. The congenital infection as well as postnatal infections like the bacterial meningitis, this all are the cause for the hearing loss. And that is why For routine screening for each and every newborn, the OA is okay. But those who are NICU graduate, who have received phototherapy for exacerbated jaundice, for exchange transfusions, or antibiotics for infections, in those cases, the child should be screened for the BERA. And if the OA is fail at that time, like 6 weeks later, the second OA is also fail in any case for the normal newborn, then also the BERA is to be checked.
Okay, so how do you compare OE versus BERA?
So OA basically screen the outer and middle ear things up to cochlea, and the BERA basically screen up to brainstem. So the hearing loss due to the inner health cell functions or the neural origins can be checked only by the BERA, while the cochlear loss and up to cochlear loss can be checked by the OA. So BERA is definitely better than the OA. Okay, and the sensitivity of BERA is more. It's almost 100% is sensitive compared to OA.
Okay, thank you, Dr. Biraj. So every newborn has to be screened for hearing, preferably before 30 days of life. So normal newborn screen with a OE and repeat OE at 6 weeks. If fails, they have to be screened with a BERA also. And every high-risk newborn, you have to do a BERA after 34 weeks of gestational age. So is there any legal aspect of if a neonatologist fails to prescribe OE or a BERA for an ICU graduate, Dr. Biraj?
Yet there are no much case reports, but it's again the dilemma. Like nobody has reported till now that if somebody has not prescribed the hearing test, but in future they may come up with. So definitely, what is ideal is to be done. That's what I feel.
It's always prevention. Is
No, but as like people are coming up with the retinal screening and the premature babies with our premature retinopathy of prematurity screening, it's going on very well established. And sometimes if it is missed out, the people do complain, and there are some legal implications for that also. So once the awareness occurs for hearing screening also, there may be some legal implications afterwards with the people coming out. So it's better to screen every baby.
yes.
Yeah, till the time there is no universal screening test mandatory, legally one may not sue you, but definitely this screening I practice getting it done.
So perfect. So that's what. So that's the most important thing why we came up with this topic itself. We do not still have a strict protocol for neonatal screening in our country. So every baby preferably to be screened before 1 month of age. Universal screening with OE repeated 6 weeks. If fails, do a BERA. And all high-risk newborns should undergo BERA to rule out auditory dyssynchrony or auditory neuropathy. So going on from clinical screening, we have kept our third panelist away for a long time. So Dr. Sheetal, when is the right time to do a metabolic screen? How do you collect samples? And what all types of disorders do you screen as a part of metabolic screening? So Dr. Sheetal?
Yes. Hi. So the ideal time, if we go through the DBS or the dried blood spot, so any time after 24 hours. So they say that at least a feeding of 12 to 24 hours should happen, because we are going to basically detect the metabolites. So metabolites will only be high or low once the child has taken the feeds and the body is responding favorably or unfavorably. So anytime after 24 hours, but ideal is mentioned as 72 hours. So on the third day, unfortunately, when many of the babies are discharged immediately 4 to 5 hours, then they have to be recalled either on the third day, or they can be screened, because very high metabolic disorders can show at least some screen positive, but they need to be rescreened again after 2 weeks. So the only thing is that the time frame is such that we may need to recall the patient 2 or 3 times if the screening test is highly positive or not favorable to the condition which is mentioned. And ideally, all sick and preterm babies, because they are anyways in the NICU, by 7th day of life, it is recommended that they should be screened for the routine or even the expanded newborn screening panels. So, like I said, the DBS is the water paper, what we say is used with the minimum of 5 drops. The heel puncture method is used, but important thing is we do not have to overlap the blood spots on the circles given on the card. So there should not be any overlapping until there is a free flow blood drop on the heel of the baby. It should not be put on the filter paper. Then it has to be air dried, and then it can be either stored if the parents still need some time, or it can be shipped for doing the normal newborn screening. The thing most people usually ask is instead of pricking the baby on the, after 24 hours or 40, can we do the cord blood? So cord blood is not a recommended sample because sometimes it may be contaminated with the maternal blood. So if the mother is on any drug or if mother has the disorder, then the maternal contamination may affect the results. And moreover, the baby has still not taken feed, so the metabolism has not kicked in. So you will get false negative results. And also the mother may have gone into, many either preeclampsia or any other maternal factors, which may again influence the thyroid stimulating hormone as well as the T3, T4 levels. So all said and done, the ideal time is after 24 hours. Ideal, if you ask, 72 hours. So 24 to 72 hours would be the right time to take a sample. And what disorders are screened, again, there is no consensus for that. But if you say what basic screen, if you want to start a universal screen, then everybody has a unanimous decision that at least congenital hypothyroidism, congenital adrenal hyperplasia, and G6PD should be screened in all newborns, irrespective of family history or the status. And again, based on that, you can keep adding on different disorders, based on family history positive or the parents agree to do an expanded. So you can add biotinidase deficiency, galactosemia, cystic fibrosis, and phenylketonuria. Because it was the first disorder, it needs to be respected. But frankly speaking, we have very few case reports or case studies or where we actually know the incidence and frequency of these disorders in our population. But a lot of work has been done for CH, CH, and G6PD. So we know at least that has to be done. And on top of that, if we consider inborn error of metabolism, which can present very acutely and later on long-term effects if we want to prevent, then we have to add amino acid disorders, organic acidureas, fatty acid oxidation defects, urea cycle defects, and almost more than 40-45 of such disorders can be picked up by a single DBS spot. So that is a good inclusion if we want to screen and if parents are agreeing for a little bit of extra costing for that. And because the method is different from what we will be doing in the routine basic screen. And then definitely as you search literature, there are many expanded newborn screenings which are being added. So people say, okay, why not we screen for sickle cell? Why can't we screen for thalassemia? So slowly each and every disorder which has a very good prospectus once you pick it up early and the patient is taken in surveillance and early treatment can be started, have slowly being started to be added into the disorder screening list. So US, Europe, they have very good programs, and there also statewide is different because they have the panels based on ethnicity. Unfortunately, in India, we do not have, like, we are a mixed ethnicity population. So we cannot have, okay, we'll do this, we'll not do that. So until we get some recommendations, these disorders are handled by third grade, or when, what we say as if they are affording or if they want to do or if there is a family history. You will be surprised to know that SMA and DMD has also been included in the newborn screening panel in many of the countries, SMA in Turkey and DMD in the US, because treatment is available, right? So disorders, whatever needs to be screening are going more and more than 100 disorders can be screened by a newborn screening panel, right? And the methodology will be different for each. So we can, when we use the dry blood spot, we can use it for ELISA, we can use it for immunoassays, we can do TMS, which is tender mass spectrometry. We can do GCMS by that, and we can do enzyme analysis also. So the methodology will depend on which of the basic panels you are choosing, right? So this is how we can go about for the major 4 questions which you have asked.
Dr. Sheetal. 35 years since the practice of TMS, and still we do not have a protocol here in our country. So I think we have 4 experiences which are published: Chandigarh experience, experience of Chennai, Goa, and Kerala. And I think 5 people Delhi also. Those are the 5 experiences that are published from India. But all rest other 24 states are yet to have. Hope we have a solution soon. So coming on, so from the basics of metabolic screen to specific screens. So Dr. Sheetal, so I think congenital hypothyroidism is the most important disease that we are supposed to screen. And I think other than TMS, TSH is being screened by cord blood samples also. And most of our people who practice newborn care are screened for CH. So a day 3-old neonate seeing you for the first time, day 3 heel prick TSH screening is 22, free T4 is 1.2 nanograms. And how would you proceed here?
So as per the cutoffs, right? So cutoff is, I would say, borderline. So based on that, whether you want to do just, some people just do TSH, some include T4 also, but a combination of both definitely will be better, so that we can rule out the different types of congenital hypothyroidism based on the etiology. Incidence, as you know, is very high, but when it is 22 is really a borderline. So either you can recall and do a repeat sample for the patient, or you can follow up based on family history again, or what was the status of the mother. So if TSH is more than 20, then probably we have to do a repeat TSH level to finally confirm. And cord blood and heel prick, both differences we have to know that they would be different.
So various
So yes.
ways to screen for TSH are TSH alone, TSH and along with T4,
Yes.
and TSH alone. So TSH is more sensitive and more specific for diagnosing primary congenital hypothyroidism.
Yes.
So TSH, I think more than 20 micro units per liter is recommended as a cutoff for recall for cord blood and postnatal screen samples of 48 hours, and screen TSH more than 40 micro units per liter. Take them as screen positive and have immediate recall for confirmatory tests. And mildly elevated ones, repeat the TSH at 7 to 10 days of life. So from congenital hypothyroidism, so I think that explains, yeah. So from CH to CAH. So Dr. Sheetal, again, your experience on CAH screening, its incidence, common differentials, and how you go about screening for CAH.
So congenital adrenal hyperplasia is probably the most common types of adrenal hyperplasias, and almost 95% are due to 21 hydroxylase deficiency. But there are other 4 major steroid pathway enzymes which can lead to similar presentation with the salt wasting as well as the genital abnormalities. So first of all, we need to know whether we are screening for a salt waster, or along with that, we have a male or the female abnormality of the, or what we say as DSD. So depending on that, the differentials, again, if you have just the salt wasters, which can present with the dehydration or hypoglycemia, metabolic acidosis. So the strongest differential again is any of the inborn error of metabolism, right? So hypoglycemia and metabolic acidosis and dyselectrolytemia can be present with organic acidureas or fatty acid oxidation defects or even amino acidopathies. So when you have a salt waster with the presentation you told me of hyperkalemia or hypotension, then we definitely have to keep differentials of inborn error of metabolism. Along with that, sepsis is definitely the third differential which always comes in mind. But IEM should not be missed out based on, like, we are suspecting CH, unless it is a classic case with ambiguous genitalia. In that, we have to consider that there could be other, like in 5%, there could be different enzymes which can cause a similar presentation. So when we say elevated 17 OHP, we are mostly concentrating on 21 hydroxylase, which is the most common of the CAH. And as you can see, the incidence is quite high, and we can definitely prevent complications, and the treatment can be started giving a very good prognosis, especially for salt crystals when we start glucocorticosteroids or mineral corticosteroids.
That's the most important thing. You have a very high incidence of CAH in southern part of India from the
Yes.
public reports. So a single test of elevated 17 OHP can identify the risk, and you can very well have good treatment protocols for these babies who are identified at an earlier age and prevent adrenal crisis and death in these babies. So going on from CAH to G6PD, so Dr. Sheetal, again, what are the incidence, risks, and how do you screen for them?
Again, incidence. So we have been concentrating on these three disorders because incidence is high, right? So much so that we have our own personal variant. So when we do a genetic study, you might get a pickle, Orissa variant or a Kalyan variant or a Kerala variant. So the incidences could go up to as high as 30% in our population based on ethnicity. So it becomes very important to screen for it. We always do not concentrate on treatment, but prevention of hemolysis due to any drug intake or due to dehydration and any of the factors which can cause prolonged jaundice and hemolytic anemia can definitely be prevented if we just screen these kids for G6PD. Especially, we can concentrate, if you want to concentrate, then those kids who are in the ICU for hyperbilirubinemia and which are beyond the cutoff range, then definitely G6PD is part of the screening. The risk of recurrence is, again, as you have mentioned, I feel that it is an X-linked disorder. Initially, it was considered as X-linked recessive, meaning that only the boys will manifest this, but females will not. But now we have conditions in which females also can present with prolonged jaundice, and they may be heterozygous for the variant. So currently we are considering G6PD as an X-linked disorder, and we do not typically say whether it is recessive or dominant. So males and females both can present with mild to moderate severity. So an early diagnosis, as I've told, can prevent exposure. So we just need to give them a list of drugs, antibiotics, which can prevent, or food items which can cause acute hemolytic event, and that can be prevented in these kids. So being a preventable condition, it's cost effective to screen for it.
Perfect. So that highlights the importance of screening for G6PD in our country. So which other common disorders can be included in the routine metabolic screening?
So the term common among rares is that among the rare inborn error of metabolism, which are much more common, right? So we have like more than 450 inborn error of metabolism. Out of that, if we say that which are the most common, which can be, treated or managed with little bit of intervention by a diet or stopping some diet. If we consider those type of disorders, then galactosemia, biotinidase deficiency, phenylketonuria, and cystic fibrosis. So these are the four other, I would say, amongst the rarer disorders, the common ones, which can be included in newborn screening because they have a good prognosis if early treatment in form of diet or stopping certain food items can be offered. So they have a good prognosis.
So a note on expanded newborn screening for IEM.
Yes. So expanded, as you had mentioned in the history, as soon as the TMS came and we knew that we could screen many of the metabolites in the blood, it became very imperative that we know that how to screen for those. So there are certain metabolites like acylcarnitines or amino acids or organic acidureas, which can be picked up by TMS. Right. So we started adding those inborn error of metabolism. And currently, as I said before, approximately 42 of these common, or I would say inborn error of metabolism can be picked up with a good reflex genetic testing. So we can do TMS, but we can also offer GCMS and LCMS. So LCMS is again a technology a lot like a mass spectrometer, which is liquid chromatography, which can help us to detect even the common, or I would say the treatable lysosomal storage disorder. So currently some private labs are also offering screening for the common LSDs which have enzyme replacement therapy in the market. So these are Gaucher, Pompe, Fabry's, Krabbe, MPS type 1 and Niemann-Pick disease type A and B. So this can be included if, especially if there is a high risk, like a family history positive, previous child has died or something like that, then probably we can include this in the newborn screening.
I think in the last 10 years, screening for these diseases have become more important with the evolution of enzyme replacement therapy.
Yes, but I think we are still focusing on the high risk kids who are admitted in the ICU or NICU. So taking it into a universal, it's still a lot of thought needs to go into it, because as everybody debates that we don't have treatment for majority. So even if we diagnose, how are we going to help the baby who has already been born? But the justification is we can help the family by doing a genetic diagnosis and preventing in the next. So prevention is long term in such disorders, but definitely that is a debate that if you want, we can definitely screen. We can start with high risk and then go on for a universal.
Definitely. So methods for screening, what are the common methods for screening?
Okay, so there has been a lot of progress. So initially, which immunoassays was done or inhibitory assays was done for PKU. Now we have a whole list of disorders like hemoglobinopathy, sickle cell or thalassemia can also be screened by LCMS. And then the biomarker or CH, CAH, all can be done by DBS. And the method is ELISA or fluorescent enzyme immunoassay. And then, as I discussed, GCMS is becoming very important because majority of the organic acidureas, not majority, I would say, few might be missed if we do just the TMS. So in an asymptomatic baby, if you are doing a TMS, it's fine. But in a baby who is critical and you want to rule out organic aciduria, it should be always combined with a GCMS, or because they are volatile substances. So they will not be picked up in the plasma and they have to be done in the urine. So urine deviate, like dried blood spot, we also have dried urine spot, which can be used for screening for these organic acidureas. So the technology which we have currently is very advanced, and almost more than 100 metabolic and genetic disorders can be picked up by doing from DBS itself, right? We need not even take a venous sample. But the methods would be different for each disorder, and based on the spots and the quality, it can always also be used for genetic disorders.
Yeah, so these are the a few common screening panels available. So more importantly, so can you screen a newborn immediately post blood transfusion?
So do I have to cover this? Okay. So the answer is no, because for TMS or whatever screening we are doing is for metabolites. And once you have a blood transfusion done, you are infusing somebody else's blood, platelets, RBCs, WBCs. So there can be inconclusive results. There may be false negative or even false positive. So there is a waiting period if you want to screen for congenital CH, CH and G6PD. So because they are enzymes, and like G6PD will be released from RBC, right? So it is, we need 120 days of circulation for that. So the cutoff period is just like doing for HPLC for hemoglobinopathy. We have to wait for almost 7 to 10 days for those disorders. But for G6PD, GALT and biotinidase, which are enzymes, for that we may have to wait for more than almost 4 months. So yes, immediately after blood transfusion, you should ideally not go ahead and do a newborn screening for the different disorders.
Common ones, congenital hyperthyroidism, CAH, you have to wait for 7 days.
Yes, yes.
The other ones like G6PD, GALT, you have to wait for 120 days. So a brief history about newborn screening in India. NBS was first carried out by Dr. Appaji Rao and Dr. Radha Ramadevi in Andhra. Many state-level NBS programs have been implemented. Chandigarh, Goa, and Kerala were the first ones to start programs in the state levels. So we have, as NNF, we have NNF CPG guidelines for newborn screening. So Dr. Biraj and Dr. Nehal, could you throw some light on the classifications and how we go about newborn screening as per the NNF CPG guidelines? Dr. Biraj?
Yes. Yeah, so basically, the newborns are divided into 3 groups. Group 1 is like universal screening, or they are, should be offered the screening of certain diseases, which incidence is quite high. The treatment is going to make difference for the baby's life, and there is definitely treatment available. So those three diseases, at least those three diseases are to be screened for, or this screening is to be offered for most of the newborns. Like counseling, one-to-one discussions, ideally it should be universal, but at least you should try to offer the CH and G6PD for all the newborns. Then those who are having a high risk. So this are the, yeah. So so those who are having a high risk, like those who are having history of sibling death, or those who has a seizures disorder, mental retardation, or any family history, those babies should be offered extra. Other than all those three diseases, they should also be offered for the PKU, homocystinuria, alkaptonuria, biotinidase, cystic fibrosis, sickle cell disease, galactosemia, MSUD, and tyrosinemia. These are the diseases to be offered to high risk group. And those who doesn't have any financial issue, then ideal thing is you just offer them the expanded newborn screening test. So if finance is not the issue, then they should be offered the comprehensive newborn screening test, all metabolic screening test, as well as hearing screening test, pulse oximetry screening test, each and every year.
So before we wind up, so a note on preterm screening, Dr. Nehal, would you like to?
Yes, so preterm screening nowadays it is very much important, and especially the HB and PCT for the anemia of prematurity. That generally we look for every baby who is there in our NICU, but we need to check for the when they are in NICU and whether they are doing well or not. For that, it is sodium level which is important for the growth of the baby, because hyponatremia and the hyponatremia both are catastrophic for such. They have very immature immune sodium absorption, and there is less sodium in the breast milk also. We do know we also supplement the low birth weight babies and the preterm babies with the calcium and phosphorus. Along with them, the alkaline phosphatase needs to be screened. The neuroimaging, because they may have been gone from with the very many insults, like hypoxia can occur at any time of the NICU stay, or any of the insult can be seen when they are screened in the neuroimaging after 3 months. The ROP screening nowadays, it is must, at the government guideline is also there for the compulsory ROP screening. Initially, only the preterm babies were screened for ROP, but now the guideline is that we need to screen each and every NICU graduates for the ROP screening and OAE both. So for preterm, these are mainly the screenings which are required.
So it's very important that we document all these screening methodologies for preterm, any high-risk baby. And I think most of the litigations that our fraternity has faced has come out with the retinopathy of prematurity screening. So cutoffs may be different for all these screening protocols. So before we wind up, take home, universal newborn screening should be implemented in all parts of the country, at least for 3 most common conditions: congenital hypothyroidism, CAH, and G6PD deficiency. Screening should be done after 2 days and before 7 days of life. Screening done prior to 24 hours has to be rescreened by 2 weeks of life. Sick newborns and preterms has to be screened by 7 days of life. Universal hearing screening has to be practiced over targeted screening, and congenital heart disease screening is a very simple, cost-effective measure. And newborn screening is a program and is a comprehensive program and does not end with the result of a screening test. Thank you very much. So any questions, we are free to take the questions. So I think we have a few questions in the chat. Can simple torch be used for checking red reflex? So Dr. Nehal, would you like to answer that question?
Can simple torch
replace an ophthalmoscope for checking red reflex? I think there is no evidence of using.
No. We need to have an ophthalmoscope, and actually, as a pediatrician, we should have an ophthalmoscope and also the otoscope in our OPD also. So it's better to have an ophthalmoscope. A simple torch with the wide projection may not be sufficient.
Yeah. Perfect. So another question was basic screen cost in private labs. So usually costs anywhere between 500 to 1,000, which Dr. Sheetal has already answered in our chat. Treatment for biotinase deficiency, biotin tablets 5 to 10 milligrams per day. That's it.
There are separate tablet biotin which are free form. So thinking that we can give multivitamins which have biotin, it will not be so useful in children with biotinase deficiency. So we need to have those tablet biotin free form.
Thank you, Dr. Sheetal. Any further questions? I can see a lot of familiar faces. Good evening, Somshekar sir.
Good evening. Good evening. Hi.
So I must
Nice.
thank the panel for finishing such a long topic in a stipulated time of 1 hour. I mean, to a moderator as well as the experts. Can I request Rituparna to present a certificate of appreciation?
Yes, sir, sure. Just give me a minute.
One more question has come up. Dr. Aditya Mohapatra has asked, any special machine is required for screening or it can be done in ELISA method? Dr. Sheetal?
So it depends on which condition you want to test. So conditions which I told you before, which can be done by ELISA, then you can do by that method. So they have the specific kits with the calculations and everything. But for inborn error of metabolism and like hemoglobinopathies, you have to need either a TMS, which is tandem mass spectroscopy, or GCMS, which is gas chromatographic mass, or LCMS. Or hemoglobinopathies, we can use HPLC, but now the trend is that we can do it on LCMS, so we don't need another machine, or we can definitely validate, but we know the limitation of HPLC. There can be, some of the variants are missed by the HPLC. So LCMS is becoming to be more specific to picking up even the rare hemoglobin variants.
So can I say something? I think machines are there, but the whole point is I think every state should probably have 1 or 2 testing centers and not many more. The general thing is to not to have many machines at every place, because all of them require to be standardized on a regular basis. Having 1 or 2 machines in a state with all the centers sending samples to that one particular place is more helpful rather than having multiple labs in a state doing the same thing over and over.
I agree totally, because the interpretation of the metabolites is very, very critical to give the accurate interpretation of the low and the high. So I agree totally, and quality control becomes difficult because sending the sample, as many branches as there, so many hands are used. So the false positive, false negative increase, and then the interpretation also is not okay if they are not qualified labs. So I agree totally with sir that every state should have a tertiary care center where all samples from wherever they have started doing it should be presented at one place, and quality control.
Another important question has come. Can we put in an IV cannula and collect blood in 1 cc syringe and then blot on the paper? A question?
Yes, that is also okay. The condition being that for what you are pricking the baby, right? So I am not sure if any asymptomatic normal baby a parent would allow to put, but yes, it is okay, but it should not be from an EDTA to a thing. So you can put the cannula, the fresh blood sample which comes, the initial, if you can just dab it off, the next 5 drops you can directly take. Advantage being there will not be any overlap and you will get a good amount. So it can be done. There is nothing wrong in taking DBS.
Maybe the times when parents don't agree on day 1 or day 2, at that time, on day 5th, when we are pricking for the bilirubin, if the child is ecteric, at that time, same time, we can collect, combine the sampling and avoid one more prick to the baby.
Yes.
If you're pricking the baby for another reason, well and good, you can do that. But if specifically for doing a screening, it's better you avoid putting in a cannula and stick onto the heel prick sample.
So there are special prickers available which will allow you to take blood drops. So whatever lab you are sending the reports, they usually give you the pricker, which is a thicker size than the lancet of the way we just collect the blood for the RBS. Similarly, you can collect with a thicker pricker.
Yes.
So, Dr. Vishnu, in the Kerala, you have hub and spoke method under NHM.
Yeah.
Yeah.
So we have 3 central labs which do screenings in 3 different places of the 3 different zones of the state. So the samples are collected from the birthing centers in the state, and they're by NHM and processed in a single central lab of that. So that's how they practice. So the entire project is called Shalabam project, where VBD is combined along with metabolic screening, essential metabolic screening also for 3 diseases.
So is that data published, or is that data for how many years the data?
Yeah, sir. The sad part of that is that the project is confined to government birthing centers only. So we have been trying and pushing hard to like extend that to all delivery points. So the funny aspect about Kerala is 78% of deliveries happen in private centers and 22% happens in government centers. So only 22% are catered with this project. So I hope.
But even the data is not kind of published or accepted.
Not yet, sir. Not yet.
Because Goa did this for the state in 2010 and 2011. I think they're still doing it on and off, but even they have not kind of published the data.
Chennai, Goa, and Chandigarh are published, sir. We are yet to get the published data from Kerala, and I think Delhi also has started. So both these states' data are yet to be published.
Good afternoon, sir. Myself, Dr. Aditya Mahapatra from Odisha. Actually, we have started this program in a project mode in one of the medical college at Cuttack recently. And this session is very useful for us because there is nobody to guide us how to do all these things. I think this will be very useful, and we will proceed accordingly, and we can have a good number of data within 1 year, because around 10,000 deliveries are being conducted in that center. So we are in the process for CH, CAH, and G6PD.
Great to know that.
Yeah.
Hope you will publish your data as.
Thank you. Thank you. This is the help from NHM. We are doing it from government side. And if it is required, we will extend it to other places also.
Wonderful.
Thank you.
Great to know that.
So one of the issues of the screening, I don't know if it was discussed, but screening tests are fine. But we found, because in 2013, Gujarat, about 12 to 15 colleges had screening being done, which we were also involved in. Screening tests are done, but diagnostic tests are not offered free sometimes. And there is paucity of diagnostic tests. So I don't know, Dr. Sharda, if you can talk about diagnostic tests after screening tests. Like, is it available for everything?
Yes. Now the trend is moving that those who are doing newborn screening, they offer a reflex genetic testing. Ideally, it should be done because either the option is either you have a screening test, because we know screening test, there will be high, there could be false positive, false negative, both. So in case of a very strong clinical phenotype or affected baby, and you are getting a normal TMS, which is screened, and you're still suspecting based on the clinical history or ABG or anything that there could be inborn, then we can directly go for a genetic test. In some case where you're getting equivocal result, option is either you repeat the test once more, so with another validated method, or you directly go for genetic testing. Advantage of genetic testing is there is very limited chance of getting unequivocal results, because if you're suspecting G6PD, then getting a variant in G6PD, then it confirms you whether the enzyme levels are low, borderline. Similarly for biotinidase, because it is a very heat labile enzyme, in so much of heat of 4240, by the time the tube is sent to the lab, wherever it is, you may not get a very good biotinidase result. But if a strong suspicion based on symptoms or previous family history, then genetic testing is better. I am sure that slowly the time will come, because many papers and many research have done are going on, which suggest that instead of all these screening methods, why can't we directly screen the baby with a genetic test? And that is going to remain for lifetime, right? So whether the baby is asymptomatic, symptomatic, or it is going to be affected later on, if you have a genetic test, you can keep the baby in surveillance. But only because of the costing currently, we cannot offer it as, okay, we'll do a universal. So genetic testing has to be an important part of any case which has come out to be positive during screening. along with a second validated test, and then you can confirm it by genetic testing, or you can directly go and do a genetic testing. So both these school of thoughts are being approached depending on the cost effectiveness of doing a genetic testing. The costings are going down a lot, so I think it will come up.
Yeah, so I agree. So what happens is in 2010, 2011, when these things started off and was being popularized, genetic sequencing or whole genome sequencing was not easily available. Forget about the cost, was not easily available. Now it's not only easily available, cost has come down and also can be finished off, and results can be given out fairly quickly. Most and there is a this is available in many government institutes across the country, and few private labs also doing it. In the US, what they do is when they have such patients who we don't have a clinical diagnosis on, they would combine metabolic screening data plus genome sequencing plus clinical data and lab values which are there from our general. And people have gotten complicated diagnosis like within a week or so, which was not possible previously. And it's not across all the US, but maybe in 4 to 5 centers in the US, which do this genomics, they do whole genome sequencing for many of the newborn babies who are not diagnosed.
So probably they are doing targeted gene panels, because we have those disorders which they have listed that these are what we are going to screen for based on ethnicity or whatever. And for those, they have a targeted gene panel. So it is known as TGP. And probably whole genome sequencing for newborn screening is still not accepted by majority of the clinicians as well as researchers, because there are a lot of ethical information or if you don't do a pre-test counseling and you do a whole genome and you get a BRCA mutation, what are you going to do? So they do targeted gene panel for newborn screening.
So this is not for babies who are like for screening, only for babies who are sick, only for babies who are sick.
Right, I agree. So because SMA or DMD and all this is not going to be picked up. So either you start adding CPK in newborn screening. For SMA, you don't have any biomarker. So how are you going to screen for these genetic disorders? So the list is going to go increasing day by day, but the advantage is the DBS card which you are sending. We can do a genetic test in the same. You need not even send a repeat sample. And in that, the thing is, even if there is an overlap blood spot, we can do it in that also. So if a baby has unfortunately died and you have the DBS card stored with any lab or with the parents, we can use that for a genetic diagnosis for a child who was critically sick and has died without a diagnosis or with a suspected diagnosis of any inborn error of metabolism or critical disorder or whatever. So that DBS also we have retrieved from the labs and done a genetic diagnosis and given to the parents to do a prenatal in the next baby. So yes, the DBS card, storing the DBS card, storing the baby's photo and records becomes an important part of post-test counseling once we lose a baby to any illness in the ICU or the NICU.
Thank you.
Thank you, sir. So can I present the e-certificates now?
Yeah, Rutpan.
Thank you.
So on behalf of NNF Gujarat, we thank all the experts today for presenting a rationale of neonatal screening. A certificate of appreciation is presented to Dr. Vishnu Mohan for being a moderator in Neonatal Pathshala. We also present a certificate to Dr. Biraj Chakkar for being an expert, as well as to Dr. Sheetal Sharda and Dr. Nehal Patel. Thank you so much. Next Wednesday, we will be having a POCUS Series 5. Everybody can join with the same ClearNet and YouTube link. See you on next Wednesday, 3:30 to 4:30. Thank you.
Thank you, everyone. I hope the session you had a seamless experience in the session. With all your due permission, I'm closing the session today and looking forward to hosting you again. Till then, stay safe and healthy, everyone. Have a nice day. Thank you, sir.
Thank you. Good day.
Thank you very much.
Bye-bye.
Bye, Neha.